Hello everyone, my name is Carla Norris. I'm going to be doing this presentation on herpes zoster for our practice pearls. Our objectives are going to include discussing the pathophysiology of herpes zoster, describing the clinical manifestations, identifying the risk factors, explaining how to diagnose herpes zoster, and listing the treatment recommendations. Let's discuss pathophysiology. First, the varicella zoster virus has to be activated. The varicella zoster virus causes two clinically distinct diseases once a person becomes infected. First, you have varicella or chickenpox. This is a childhood illness or a vaccine received in childhood. This is your primary infection with the virus that results in chickenpox or your vaccination against it. Second would be your herpes zoster or shingles from the reactivation of the virus. Herpes zoster, also known as shingles, results from the reactivation of the virus that gained access to the sensory ganglia during varicella. The role of informatics as it relates to the varicella zoster virus. It is to ensure safety and quality improvement when caring for the elderly. It can help us to determine previous history of chickenpox as a child or the varicella vaccine, as well as any immunocompromised status that the patient may have, or if they've previously been vaccinated either with varicella or Shingles. Clinical manifestations, which is how the patient is going to present to you. There will be pain, itching, burning, and a tingling sensation of the skin. The pain may be present for several days before the rash appears. Once the rash appears, it will be a maculopapular rash that develops into clusters, oftentimes turning into blisters, normally on one side of the body and usually heals in 2 to 4 weeks. The rash can develop for 3 to 5 days once it begins. The thoracic and lumbar dermatomes are most commonly affected. Trigeminal herpes zoster infection may lead to potentially severe conditions if not recognized and treated. In the image, you'll see a patient who has been affected by the trigeminal herpes zoster infection. The complications can include encephalitis, post-herpetic neuralgia, permanent vision loss, and disfigurement. Interdisciplinary teamwork and collaboration in advanced practice is needed to promote quality patient care for the elderly patient across outpatient, inpatient, or maybe even rehabilitative services. Now let's discuss the risk factors associated with herpes zoster. Exposure. First, we have to be exposed. Anyone who has had a natural infection of varicella zoster virus or the chickenpox or has had varicella vaccination can develop the herpes zoster virus. Age is the most important risk factor, with our incidence increasing over the age of 50 when our varicella virus immunity declines. Immunosuppression. Anyone with an autoimmune disease, a transplant recipient, HIV infections, or recent physical trauma. Sex. More women than men develop shingles. Race. Shingles is 50% less common in the Black American population compared to the white American. The value of cultural diversity. Patients' treatment adherence, health promoting behaviors, and health outcomes are directly linked to holistic, patient-centered, culturally sensitive health care. So how do we diagnose herpes zoster? The diagnosis of herpes zoster is usually based solely on the clinical presentation of the patient. We have a unilateral rash, usually painful vascular eruptions, with a well-defined dermatomal distribution that rarely crosses over the midline. If we cannot diagnose on clinical presentation alone, then we will move on to laboratory confirmation with polymerase chain reaction testing, direct fluorescent antibody testing, or viral cultures. Ethical considerations. Providing ethical care requires better understanding of the older adult. We need to be aware of their needs, and we need to make an effort to solve their problems, even if this means helping them find cheaper medications or medications that they may can afford to treat their illness. Treatment recommendations include antivirals such as valsaclavir, famciclovir, and acyclovir. All three of the antivirals need to be taken for 7 days, with acyclovir needing to be taken 5 times a day. This would be hard for an elderly patient to stick with the treatment regimen because 5 times a day is a lot of medication to take. Adjunctive therapies would include gabapentin, oral glucocorticoids, tricyclic antidepressants, which we need to be careful of because this medication is on the Beers list, topical creams, and analgesics. Vaccinations. This Shingles is recommended for adults 50 years and older. The immunocompromised adult 50 years and older should get 2 doses of the Shingles 2 to 6 months apart. If previously vaccinated with Zostavax, adults should still receive this Shingles vaccination. Zostavax is no longer used in the United States. Health policy and financing. We need to have Congress optimize the balance in payments between remote and in-person care for adults, promote policies that ensure education and resources for the integration of telehealth into existing and new evidence-based medicine. I hope you guys have enjoyed this presentation, and here are my references.